Namaste. This is week 8, lecture number 3. I am going to talk about symptom management in respiratory system. As we discussed earlier, symptoms are very common in palliative care patients, and if they are not relieved, patient remains in distress, it increases their suffering and it affects their quality of life. In respiratory system, we will be talking about management of dyspnea, management of death rattle, cough and hemostasis. Dyspnea is the word derived from Greek language. Dys means bad or difficult and neo means breathing, it is a bad breathing. And almost 70% of the cancer patients has dyspnea few weeks before death, and very severe dyspnea in 25% of the patient has been reported. It is an unpleasant awareness of breathing and causes difficulty in breathing, and it is a subjective symptoms. One can define dyspnea as it is a subjective sensation of difficulty in breathing, not necessarily related to exertion. Patient may feel dyspnea at rest, even if he is lying in bed, he will be dyspneic, he will be having difficulty in breathing, and it compels the individual to increase his ventilation and reduce his activity. Although subjective, its effect on function and other activities of living may be objectively observed. You can see that if a patient is in dyspnea, he cannot walk up to the bathroom. After coming out from the bathroom, he becomes more dyspneic, more breathless and very so much in distress. How patient describes dyspnea? He will say there is a tightness in my chest. He will say that there is a air hunger, I am not able to breathe enough and I become breathless, air hunger is there, and there is a feeling of suffocation and drowning. There are two types of dyspnea: intermittent dyspnea, which is precipitated by exertion. At rest, patient is fine, sitting, talking, lying down in bed is fine. As soon as he goes to bathroom or goes out and have a small stride and comes back, he becomes breathless, like on walking, bending, or even just by talking also they become breathless. And sometimes at dyspnea at rest also in few of the patients, and this causes lots of anxiety, because patient feels that even if I am taking rest, I am not able to breathe properly, and that causes panic attack, and patient feels that now death is approaching, I am about to die, because he is not able to breathe enough even at rest. Few causes of dyspnea described over here, mainly they are related to lung or heart. Firstly, cancer of lung and lung having metastasis because of other primary cancer somewhere else. Then lung related surgery where half or full lung is removed and all such thing. Radiation given to the chest will cause fibrosis of the lung, and muscles will be atrophied, and that can give dyspnea. Another cancer related problems like low hemoglobin, anemia or cachexia will also cause dyspnea. Cancer patient might have other concomitant disease like COPD, that is asthma, heart failure, etc., and which can give dyspnea. What causes dyspnea in cancer? Firstly, obstruction of the airway because of the tumor or airway collapse or tracheoesophageal fistula, which causes dyspnea and air hunger. Other pulmonary causes are lung cancer, lymphangitis, carcinomatosis, lung collapse, etc., and consolidation. Cardiac problem which causes dyspnea are pericardial effusion, pleural problem causing dyspnea are pleural effusion, tumor in the pleura, etc. In mediastinum between the two lungs, if there is a tumor causing pressure on the large vessels of the heart and phrenic nerve palsy, that can give dyspnea. In thoracic cage, suppose there is a tumor outside the chest or on the chest wall, and it cancer on diaphragm cancer or tumor in diaphragm and muscle fatigue, that will cause dyspnea. And extra thoracic, in abdomen there is a huge tumor which is causing pressure on the diaphragm and patient is not able to breathe properly. How can you measure dyspnea? By asking patient or by verbal rating scale, you can see it is mild, moderate or severe, or by on a VAS scale where 0 number is no dyspnea and 10 number is extreme dyspnea, and patient can put the mark on this line and say what is the score of his dyspnea. Other objective test by measuring pulse oximeter, peripheral oxygen saturation. Usually it is not reliable because many other factor also affects oxygen saturation in pulse oximetry. When patient is in dyspnea, there is no need to undergo very elaborative investigation. Sometimes chest X-ray will be helpful to rule out pleural effusion or pericardial effusion. Pulmonary function test can be done or arterial blood gas analysis, and lung scan only to rule out pulmonary embolism. Then and to treat it effectively, this is required. How you will manage breathlessness or dyspnea? First of all, ask this question: is this caused by cancer, or is this cancer curable, can be modified, or is this dyspnea has happened recently or the patient is deteriorating recently? Is there any infection or effusion which can be treated? So, the final thing is correct the correctable. Like if patient has pneumonia and become recently dyspneic, you can treat pneumonia with antibiotic and you can correct the correctable. Secondly, if patient has got effusion, pleural effusion and becoming dyspneic, you can tap the infusion and make patient comfortable. So, general principle again in palliative care, always correct the correctable first, but whatever method or treatment you adopt, it should not add to the new problem, like side effect of the drug or interaction or financial burden to the patient. It is worthwhile, first you find out whether whatever treatment you are going to suggest, is it worthwhile. Like if patient is having huge tumor in a mediastinum and surgeon asks that we can attempt a resection, one should give a thought that by just resecting a part of the tumor, is it going to help the patient, is it worthwhile, like this. So, discuss the treatment option including no intervention with patient and family, whether even if we are not going to do any intervention, discuss with the family that how it is going to be affect the patient's future. Respect their decision, involve them in decision making, and emphasize on quality and not the longevity of the life. As you know, the cancer may not be curable, then what is important is quality of life. Coming to treatment of the dyspnea, depending on the type of depending on the cause, you can treat the cause. Like respiratory infection, treat with antibiotic, expectorant and physiotherapy. Patient is having asthma, then give him steroid or bronchodilator, and COPD malignancy, then because of malignancy patient is having obstructive lung disease, then you can give respiratory sedative, benzodiazepines or opioids. Other things which you can correct, like correction of anemia to certain extent by blood transfusion, correction of ascites by tapping the ascites, pulmonary embolism by giving respiratory sedative and anticoagulants, and heart failure by giving diuretics and ACE inhibitor and digoxin. There is a definite role of opioids in dyspnea. Many doctors who are not aware about this and has not used oral morphine, they are always hesitant. How can you give morphine to a patient who is dyspneic? Because morphine itself causes respiratory depression. But that particular action of morphine is useful in patient having breathlessness in terminal stage of the disease. So, opioid acts on the CO2 sensitivity medullary respiratory center by making it less sensitive to CO2 accumulation. So, in dyspnea there is a CO2 accumulation. By making this center less sensitive, you can decrease the respiratory rate of the patient. Then it reduces the inappropriate and exaggerated respiratory drive. So, patient will not make unnecessary effort and it will reduce the ventilatory response to hypoxia and hypercarbia. By slowing respiration, breathing is made more efficient and sensation of breathlessness is reduced, and by morphine causes somewhat pain relief and somewhat feeling of well-being, that will also reduce the anxiety and it will reduce the dyspnea. So, reduces the vent response to hypercarbia, hypoxia and reduces respiratory rate. So, morphine has got definite role to play in treatment of dyspnea or breathlessness. Dose is, if the patient has never received morphine, you can start with the dose of 2.5 to 5 milligram given 4 hourly by oral route, and you can titrate the dose after 24 hours, 48 hours. If patient is already on taking morphine, then 50 to 100% of the regular dose you can continue or increase a dose by 50 to 100% and continue it 4 hourly. Opioids or morphine does not cause respiratory depression in cancer in the dose used for pain control. So, in presence of pain, opioids does not cause respiratory depression in cancer patients. This you must keep in mind, and in fact, it helps the patient and makes him less dyspneic and makes him comfortable and anxiety free. Other drugs which you can be used for dyspnea are bronchodilator, benzodiazepines, that is for a sedation of the patient, and it acts as a anxiolytic drugs like diazepam, midazolam or lorazepam, opioids and steroids. These are the drugs used for breathlessness. Oral salbutamol tablets for the as a bronchodilator or terbutaline, deriphyllin, salbutamol in nebulizer or salbutamol inhaler, and ipratropium 6 hourly as a nebulizer will reduce the will cause bronchodilator and it will reduce the dyspnea to some extent. Other drugs, as I said earlier, steroid dexamethasone 4 to 8 milligram per oral dose daily. Look for benefits within 7 days and then taper the dose. Benzodiazepines like lorazepam 1 to 2 milligram sublingual, midazolam or diazepam and theophylline can be given. Is there any role of oxygen therapy in dyspnea? This is the general trend that as soon as patient becomes dyspneic or breathless, we immediately give oxygen. This is the general practice in any healthcare setup. But is oxygen therapy really helps the patient? In palliative care, we always look for pros and cons whenever we start any additional treatment to the patient. So, oxygen helps only if it is the dyspnea is because of hypoxia. If saturation is falling, and by you can check by giving oxygen, if the saturation rises, you can continue oxygen. So, pulse oximetry simple thing which can confirm the hypoxia and improvement in saturation after oxygen you can judge. Sometimes it helps in sudden episode of hyperventilation due to panic. Sometimes usually patient is fine, normal, talking and walking around, but sometimes because of some stress he becomes suddenly dyspneic. In these cases, if you give oxygen and maybe because of it is pulmonary edema or pulmonary embolism, or maybe benefit in this type of patient who are having COPD. But controversy is sometimes oxygen acts as a placebo effect. Patient feels comfortable, no, now I am given oxygen, so I am going to be relieved of dyspnea. So, give oxygen trial intermittently. If patient improves, continue oxygen. If patient does not have any effect on oxygen saturation after giving oxygen, you can discontinue intermittently. Avoid oxygen dependency. Because of oxygen dependency, sometimes you have to keep patient admitted only. Patient cannot be sent home because there is no they might not have provision at home. So, give oxygen intermittently. You can explain the situation to the patient and relatives prior in advance and take a consent that no oxygen will be given, and if they agree for it, do not start the oxygen. Because its usefulness is always questionable. It limits the mobility of the patient, and sometimes because of oxygen mask, patient is not able to communicate with the relative. So, during terminal phase he cannot communicate with the relative and talk to them. So, it becomes a barrier between patient and family, and sometimes it becomes a expensive outcome for the patient's relative, because patient has to remain hospitalized because of that and causes inconvenience. So, much dependency has been caused by injurious use of oxygen leading to habit. So, it is a as I said earlier, in healthcare it has become habit to just start oxygen, which should not be practiced in palliative care. Other non-drug measure in palliative care, any symptoms we always talk about its management in terms of non-drug management and pharmaceutical management. So, there are many small things which you can practice at home also, and it can make your patient comfortable. So, in dyspneic patient, the non-drug measure contains a calming presence and presence of sight of other people. He should not be left alone, he should be able to see his relatives and close one is surrounding him. There should be cool air with fan and open windows, and this breathing exercise little bit, ask him to take deep breath, hold the breath, relaxation therapy, complementary therapy and modification of way of life. You plan his daily rituals, like he should not go and finish all the rituals at a time, one thing at a time. Firstly, he will go and brush the teeth and come back, relax when his breathing becomes normal. After some time he can go for bath like this. So, plan his activities. Reassurance is very important, education of patient and about his activity planning and explanation is very important. Calming presence of loved one, trial of diazepam and opioid and oxygen and breathing exercise. Terminal breathlessness. When patient is about to die, he is likely to become very breathless, and we call it terminal breathless. At this hour, patient has lots of fear and suffocating type of feeling and fear of death. So, relief of terminal breathlessness is most important in palliative care scenario and when you are giving end of life care. So, no patient should die with distressing breathlessness. Failure to relieve terminal breathlessness is failure to utilize drug treatment correctly. There are many drugs available to treat this terminal breathlessness. So, which are the drugs? First of all, if patient is on opioids or even if not on opioid, you can start tablet morphine 2.5 to 5 milligram 4 hourly and it acts as a sedative as well as anxiolytic. Then add midazolam either in form of infusion or subcutaneous route, or midazolam injection you can just give through nasogastric tube or in oral cavity in mouth also patient will absorb. If patient gets confused or agitated, you can add haloperidol 1.5 to 5 milligram 3 times a day, or chlorpromazine and promethazine has both been reported to improve breathlessness when combined with opioids. So, here you have to sedate the patient, make him as calm as possible and that will help him to relieve breathlessness. Nursing care again very important. Patient should be allowed to sit in a semi sitting position with lots of support on the back and lean forward. Sometimes patient wants to lean forward and lie down, put his head on a bench or a pillow in front of him. Fresh air from the window, table fan, oxygen through nasal prong and not mask. Nasal prong will allow him to speak and mask will impede the conversation, and frequent sips of water can be given. Another symptoms which we come across in palliative care setup, particularly towards end of life, is death rattle. This is because of collection of the secretion at the base of the mouth, base of the tongue, and tongue falling backward because of the relaxation of the muscle. So, that causing rattling sound produced by secretion in the hypopharynx, oscillating in time with inspiration and expiration. During respiration it gives time. It occurs in 30 to 50% of the patient, and though patient is not aware about it, only relatives and family members hears the death rattle and they become anxious that he is not able to breathe, he is suffocating. So, they are anxious and that is why we have to relieve that. Death rattle can be managed by non-drug measure. First of all, explain the relative. You can make the patient semi prone or on one side of his either left side or right side, make him comfortable and take out the secretion by suction or by putting a gauze finger on the gauze and just cleaning out the secretion from the oral cavity. You can give hyoscine or glycopyrrolate is the common drug given for this. This is for the drying of the secretion at this time. So, death rattle, though it lasts for few hours, but it is very disturbing as far as patient's relatives are concerned and can be managed very easily with few non-drug measures only. Thank you very much.